Good afternoon. We are Healthcare Innovation Team 5. Our goal today is simple. We are asking for approval to run a 12-month pilot of PFA in the PE lab with vendor training, tutoring, and quick success metrics.
Let us begin with the problem we must solve. Atrial fibrillation is common and growing. In 2017, about 37.6 million people worldwide were living with AFib. About 3.05 million new cases occurred that year. Over the last 2 decades, global incidence increased by about 31% and prevalence increased by about 33%. Projections show that the overall burden will rise by more than 60% by 2050. In practical terms, that means more strokes, more hospital admissions, and more readmissions. The pressure on our EP capacity will continue to climb. Now let's connect this to our hospital environments. Our EP labs face longer wait lists and increasing overtime. Thermal ablation works, yes, yet procedure length and the risk of collateral injury limit how many cases we can complete each day. We need a therapy that keeps clinical effectiveness, improves safety signals, and shortens procedure time. Pulsed field ablation is designed to do exactly that. So you may pose the question, what is PFA? Pulsed field ablation is non-thermal. It delivers ultra-short, high-voltage pulses that causes irreversible electroporation in cardiomyocytes, heart muscle cells. Because the myocardium is more susceptible than surrounding tissue, PFA can create selective lesions while largely sparing surrounding anatomical structures such as the esophagus and the phrenic nerve. This mechanism lowers the risk of heat or cold injury and supports a simpler, more repeatable workflow. Before recommending a pilot study, we followed a discipline evaluation. First, we used Herzlinger's 6 forces to anticipate adoption barriers and enablers. Second, we used the quadruple aim to access patient experience, population, health, cost, and provider well-being. Third, we used a value proposition canvas to translate those insights into pain relievers and gains. We anchored the proposal in 3 cohort studies, the Ablation study, the Pulsed AF study, and the Admire trial. And we built a conservative throughput design and budget impact model for our labs.
Let's begin with a randomized control trial. In the Advent trial, 607 patients with paroxysmal atrial fibrillation were randomized to pulsed field ablation, PFA, or thermal ablation. At 1 year, treatment success was 73.3% with PFA versus 71.3% with thermal, meeting the criterion for non-inferiority. Serious device or procedure-related events occurred in 2.1% of PFA cases and only 1.5% of thermal cases. Mean total procedure time was 106 minutes with PFA compared to 123 minutes for thermal, a reduction of roughly 17 minutes per case. Fluoroscopy time was higher for PFA at 21 minutes versus 14 minutes for thermal. But importantly, pulmonary vein cross-sectional area loss at 3 months was smaller with PFA, supporting a structural safety advantage. Next, the pulsed AFib pivotal study. 300 patients were treated across 41 centers. At 12 months, effectiveness was 66.2% for paroxysmal atrial fibrillation and 55.1% for persistent atrial fibrillation. The primary safety event rate was just only 0.7% in each group. Imaging sub-studies detected no clinical esophageal injury, nor phrenic nerve injury, and no moderate or severe pulmonary vein stenosis. Patient reported substantial improvement in quality of life with an AFEQT score increasing by about 29 points at 1 year, while an MRI substudy identified silent cerebral lesions in 8.9% of cases, but this was without measurable cognitive decline. We will monitor this through a targeted substudy in our pilot. In the ADMIRE pivotal trial, primary effectiveness at 12 months was 74.6% for paroxysmal atrial fibrillation. First pass pulmonary vein isolation rates were high, and major complications were uncommon. Both procedures and ablation times were comparable to or shorter than those of thermal ablation. These findings reinforce that PFA can deliver consistent efficacy with efficiency gains. In summary, the clinical trial evidence is clear. PFA delivers a 1-year effectiveness comparable to thermal ablation while showing fewer structural injuries and shorter procedure time. The primary trade-off, however, as noted in the ADVENT trial, is higher fluoroscopic time. A factor we'll manage proactively through our ALARA, which is as low as reasonably achievable radiation policy and track as a formal safety endpoint. This table summarizes the direct ADVENT trial comparison. 12-month success was 73.3% with PFA versus 71.3% with thermal. Serious adverse event was 2.1% versus 1.5%. Procedure time was 106 minutes versus 123 minutes. Fluoroscopic time was 21 minutes versus 14 minutes. And pulmonary vein area loss was smaller with PFA. These are the exact benchmark we'll replicate and monitor within our local pilot dashboard.
Let us translate minutes into capacity. If we save about 17 minutes per ablation, the time bank adds up quickly. With 4 ablations in a day, that is around 68 minutes saved per day. Over a 5-day week, that is about 340 minutes, which is almost 6 hours of room time. Even if turnover times limit additional full cases on a single day, the cumulative effect across the week supports more on-time finishes, fewer overruns, and the ability to pull forward add-on cases. To make our estimates transparent, we use published procedure durations. ADVENT reports total procedure time for thermal at about 123 minutes and PFA at about 160 minutes. Pulsed AF reports skin-to-skin times between 134 and 145 minutes. When we must plan for skin-to-skin, we use a conservative median of about 140 minutes. We will replace these with our real site data as soon as the pilot begins. Now to the economics. We test 3 time savings scenarios, 10, 17, and 25 minutes per case. We combine those with 3 device cost scenarios, lower than current, the same as current, and higher than current. Throughput scales with time saved. For a baseline of about 123 minutes, a 17-minute reduction implies an efficiency gain of about 14%. Weekly contribution margin equals added case revenue minus room and anesthesia time cost, and any device cost difference, plus savings from fewer complications when they occur. Even in the conservative case with 10 minutes saved and the same device cost, the effect is neutral to positive because room time is the primary bottleneck. The pilot will convert these modeled ranges into measured results and will report margin per case and per lab week. Patients feel the difference when procedures are shorter and collateral injury risk is lower. Because PFA is non-thermal, patients often have less discomfort and may recover faster. In pulsed AF, AFEQT quality of life scores improved by about 29 points at 1 year, which is a meaningful change. If our pilot reproduces the time savings and low complication rates, we can schedule appropriate cases at community sites, shorten wait lists, and reduce travel. That supports patient experience, population health, and provider well-being. Payment is straightforward. The inpatient code for PFA is ICD-10 PCS 02583 ZF. It became effective for discharges on or after April 1st, 2024. It maps to the same MSDRGs as other catheter ablations 273 and 274, so base payment does not change. Professional CPT codes are unchanged this year. The code lets us track PFA precisely. We will update the charge master as pilot starts and share outcomes with two priority payers at months 2 and 6. Value-based purchasing rewards higher outcomes at lower total cost. If PFA maintains effectiveness and reduces complications, readmissions, and length of stay, our value profile improves. We will manage the pilot as an episode of care and engage payers once early outcomes are available. Risk will be actively managed. We will start with 2 weeks of vendor proctoring and competency checkpoints. We will use standardized protocols for vascular access, anticoagulation, esophageal protection, phrenic nerve monitoring, and tamponade management. Since Advent showed higher fluoroscopy time in PFA, we will track radiation under ALARA. Given the pulsed AF MRI signal, we will run a targeted MRI substudy with consent to monitor for silent lesions. Here is how we will run the pilot. Duration is 12 months. The primary clinical endpoint is 1 year freedom from atrial tachyarrhythmia after the blanking period with standardized rhythm monitoring. Safety endpoints include major complications with and 30-day admissions. We will include a sub-study for pulmonary vein stenosis. Operational endpoints include skin-to-skin time, time from first to last application, fluoroscopy time, anesthesia minutes, turnover time, cases per lab day, and overtime hours. Financial endpoints include device and supply cost per case, room and anesthesia time cost, downstream complication cost, and contribution margin per case and lab and per lab week. Patient-reported outcomes include the AFE-QT and time to return to normal activity. Governance includes weekly check-ins during ramp-up, monthly operations huddles, and quarterly executive reviews.
Our continuation rule is clear. We continue only if 4 thresholds are met. Success of at least 70% at 1 year. Major complication at most 3%. Mean procedure time reduced by at least 10 minutes versus our baseline. Contribution margin per case remain positive compared with our current standards. If any threshold is not met, we will revise or we will stop. Here is our timeline to day 1. In week 1, we handle contracting, charge master updates, and start scheduling. In week 2, we complete logistics and start education. By week 3, we begin the first porter cases. In month 2, we roll out the first operational dashboard. Month 3 brings our first executive review. From there, we will continue with monthly operation hurdles and quarterly executive review through month 12. Let me close with our request. We are asking for approval of a 12-month PFA pilot in the EP lab. This approval covers capital and disposable. rental training and portering and activation of the inpatient code for tracking. We will report clinical, operational, financial, and patient-reported outcomes on a monthly and quarterly basis. At month 12, we will recommend whether to scale up or conclude the program. PFA delivers thermal equivalent efficacy with fewer collateral injuries and shorter procedures. It gives us a credible path to more capacity and better value for our patients and for our hospital. Thank you. I promise you this is great plan. Please make your decision today.